Dr. Alex. I'm changing, giving you the presentation, this thing, Dr. Alex. Over to you, Dr. Alex Varghese.
Right. Raj, you'll be able to change the slides?
I'll change it.
Thank you. Good afternoon, everybody. And I guess it is Bakrid or Eid al-Adha in this part of the world, and it's Varmahalakshmi festival in India as well. So wishing everybody a happy Eid and Varmahalakshmi before we start. This slide, which is the start of the slides that I've shared here, should give an understanding. I guess a lot of you already know it, but I was just showing you a picture of where these countries stand. In GCC, you have 6 countries, and in ASEAN, which is the Association of Southeast Asian Nations, you have around 10 countries. I've had the privilege of having worked in GCC, 6 years in Dubai, 4 years in Kuwait, and 3 years in Indonesia. So this is probably one of the reasons why I'm talking about the benefits and the learnings of quality and accreditations between these 2 regions. Next slide, Raj. The contents are specific and simple, and I guess by the end of this, the idea is to give you all an overall picture of what's happening in different parts of the world. It should go around 20-25 minutes and got 9 to 10 slides to give you a broader understanding of what's happening in these 2 regions. Thank you. Next. The first one is on the introduction, so you get an idea of the demography and the comparisons when we are talking about. The Gulf Cooperating Council was founded in 1981. The ASEAN was a decade or 2 earlier, in 1967. The member countries include 6 in this part of the world, and then you've got 10 in the ASEAN region. Going to the most important point here, if you look at the population, you would see that GCC is smaller in comparison. It's got around 54 million, a bulk of who live in Kingdom of Saudi Arabia and Oman, which should constitute to half of this. In ASEAN, you have 60 or 65% living in Indonesia, and if you put Indonesia and probably Philippines together, that should be close to 70% of the population that we're talking in the ASEAN region. If you look at the number of hospitals, again, you see a reasonable comparison there. They've got around 738 both private and government hospitals in GCC, whereas in ASEAN you have around 6,640 hospitals that are available. I managed to get data on JCI accreditations, and therefore I just put that up for reference, although that is not the only accreditation that is available in these parts of the world. There are several other accreditations which I would talk about as we move ahead into the other sessions. The point to note here is that if you look at JCI was probably an early starter in GCC. They had an office here in Dubai way back in 2004. If you look at the number of institutions that are accredited, it's a staggering 50-55% which are accredited, and mostly private organizations, and you've also got the government organizations accredited here in this region. My hospital, where I currently work, has been the first one to be accredited. We've got both the accreditations here, the Joint Commission accreditation and the Canadian Standard accreditation. If you look at ASEAN, larger country, larger framework, smaller number of hospitals, predominantly over Malaysia and Singapore, and some in Indonesia, which have been accredited by JCI. Next slide. If you look at the other elements which are key to the understanding of and comparison of these regions, you will see I'm showing or talking about the disease patterns. In the disease patterns, you will see obesity, hypertension, cardiac illnesses being the major cause of problem in the GCC, whereas in ASEAN, you've got natural disasters, disease outbreaks, chronic non-communicable diseases, and a large aging population, which is a different kind of a problem that they face. If you look at the workforce, healthcare workforce, you would see that in GCC, the nations are heavily dependent on expatriate workforce. I'm one of them, so 80% of the workforce is generally from other parts of the world who come in and who are allowed to practice and work and who are licensed to do so. Whereas in ASEAN, very similar to India, you don't allow for foreign nationals to come, especially in the clinical zone, to come in and work. They've got their own colleges and students and professionals, but the numbers, especially in Indonesia, is exceptionally low. For a 400 million population and being the fourth or the fifth largest populated country in the world, Indonesia has limitations with the number of educational institutions and professionals who come out of it. It's got 17,000, I repeat, 17,000 islands, of which 3,500 odd are inhabited. So imagine getting healthcare professionals all across to different parts of Indonesia and to be able to provide those services. So we're talking of, one piece of land in this part of the world, whereas you've got, thousands of pieces of land in ASEAN region where healthcare needs to be provided. If you again look at the GDP, you would see that it's almost in comparison to the population. You've got 3.4 trillion here, whereas it's around 9.34. And with the population, it has been, growing in leaps and bounds over the last few years. The GDP spending on healthcare is something that is important and key here. If you look for a small country or a small region of this size, they're spending close to 4%. This is past data. Currently, it's around 5.5. And both Saudi Arabia and UAE top in their spending. Whereas if you look at ASEAN region, you will see smaller countries like Singapore and Brunei doing much more. They're probably at 8 or 9% of their GDP spending. The overall average is around 4%, which is incomparable. But if you look at the population size, that is not comparable spending at all. Next slide. Next slide. Yeah. After the introduction, I've just put about a few elements that would give you a broader understanding of what the past was, what the present is, and what the future holds in terms of investments and reforms for these countries. You would see that the income within GCC is predominantly from oil, whereas in ASEAN, you've got oil, agriculture, mining, and other enablers, which brings about the revenue. The general infrastructure, I don't need to say the places that people comprehend to when you talk about GCC is Dubai, and when you look at ASEAN, everybody talks about Singapore. So in and around these regions, you find a lot of development, large scale, based on the size and the needs of the population, which is happening. They have been considering to spend much more as far as their GDP spending is concerned for healthcare. With COVID, I believe this is going to drastically change. So when they sit back during this year for the next 5 years or 10 years projection, you would find a lot more spending that needs to probably happen, at least in the ASEAN region. They're already projected to double it in the last 6 years, 7 years, but that may not be enough as of now. Healthcare services, if you look at the GCC and ASEAN, you'd see a stark difference. We've got very strong primary and secondary care network that is available in GCC. Very few tertiary care services for which people travel abroad, although it is available in this part of the world. The expertise that is needed sometimes is not always available, so people travel to the West, sometimes to India, sometimes to Singapore for advanced treatment. So you've got very strong primary and secondary care networks in GCC, whereas in ASEAN, you've got all the three, but the accessibility and affordability of the population to move into those services is far and wide, and with regions being so far off and connected by airfare or seafare, it becomes quite difficult to access healthcare in the ASEAN region for tertiary care services. Next slide. Yeah, if you look at the technology piece of it, and also the integration of quality and accreditations, you would see that there's a growing emphasis on technology on both sides. If you look at the digitization or digitalization of the economy, the highest usage of data is in the Asia and the Southeast Asian segment. It is unbelievable, but it is believable from the point of the population that the amount of data and the amount of utilization in mobile technology that is available in ASEAN is incomparable to any other parts of the world. It's way ahead of the US and even Europe per se, to say it's almost double. You've got data and connectivity which is available in both parts of the world. It's expensive in the Middle East. In ASEAN, it's more affordable, I would say. You find a lot of technologies that are coming out of this space over the years, be it in artificial intelligence, telemedicine, in trying to integrate records. GCC, or Dubai particularly, was one of the first ones to introduce mandated ICD coding, followed by ICP and CPT codings way back in 2006 and 7. So they've kind of understood, and that model has spread across to UAE and has moved on to the other 6 nations in GCC. In ASEAN, you see them evolving around that. Singapore and Malaysia, followed by Philippines, have been in the lead. Indonesia has also been doing a lot of work along those sides. Next slide. If you look at the challenges and opportunity, every challenge can be considered as an opportunity as well. Population is smaller, but very, very diverse in GCC. You've got all the nationalities living and residing and utilizing services in GCC, whereas in ASEAN also you've got a large variety of population, but the population mix is not as much as it is in GCC. They've got a larger population which is aging, disaster prone, and have limitations with resources. I've spoken about disease patterns, healthcare manpower also I did share. So each of these challenges, be it disease patterns, be it healthcare manpower, all of this can be changed, and you can already see the effects of it through the change that has been brought about by COVID. Telemedicine for the last 14 years that I've been in this part of the world has not been approved for various cultural and legal and other concerns, regulatory concerns. But COVID brought about a change overnight. Telemedicine or teleconsultations have been made approved services in the early days of COVID itself. Way back in March itself, it was approved. So for organizations like us, where telemedicine was never practiced or teleconsultation was never practiced, is currently being allowed all across GCC, and you see that happening even in ASEAN as well. This also brings about a drop in the cost, which therefore, this challenge can be converted into an opportunity if one wants to look at it. Same with healthcare manpower. The kind of sessions that we have seen, including the core sessions that are being conducted on this platform and several other platforms, all of the world seems to have transformed or moved ahead into Zoom and every other platform that is available to educate, to get CME, to get CPE. So the transformation, although these technologies were available for the last 10, 15 years, the acceptance and the utilization has changed tremendously over the last 3 to 4 months. It's like decades have changed in a matter of few weeks. You can see the kind of patterns that are evolving out of it. The same will extend to medical graduate education or nursing education, and you can see the transformation that is going to come by as we move ahead. Next slide. I don't want to spend too much time on medical tourism, but a lot has been spoken about this. Dubai does quite a bit of it for the region, and you see Singapore and Malaysia doing quite a bit of it on that part of the world. India also is a great hub for medical tourism. The key factor that sometimes people forget or institutions forget is cost. Cost is the only driver for people to move and travel. With COVID, travel has become almost full stop. So cost and whatever you do around it may not bring about results. But that said, in many parts of the world, medical tourism has not been a great winner at all. But it has been a great winner in the Asia sector, especially India, Malaysia, Singapore. Not Singapore as much, I would say Malaysia. Even Indonesia has done a lot in terms of gaining from this, because they are able to control their costs. They're able to control because they've got the consumables, they've got the manpower. They don't need to bring people from abroad to treat and manage their population. So such things bring about huge acceptance. With COVID, I can say this has almost come to a full stop. It may reopen in smaller phases as we move ahead, but I guess it's going to take a while before medical tourism is going to stand back again. It probably is going to take a year or two before this thing comes back to the way it should be or where it should have been. Next slide. Innovations, as I've shared before, lots of innovations, tons of innovations happening. I remember while I was working in Indonesia, there was an app called Ojek. Ojek was probably the Uber of Indonesia. While I was there in 2014, they were already there 5 or 6 years before that. And before I left Indonesia in 2016, they went into transporting items. Basically, what Amazon was doing via logistics and shipment, Ojek was doing on bikes. Bikes was the most accessible route of transportation. They would transport people, they would transport goods, food services, everything that you can imagine was being done on this platform many, many years ago. Likewise, you also see in Indonesia the app called HelloDoc, which is very similar to the Practo of India. Even in GCC, you can find a lot of innovations around making healthcare accessible, affordable, making it available on your mobile. You also see insurance players playing a big part in this, some of them accepting it, some of them changing with this. Insurance has been a big thing in GCC for a long time. A large percentage of the population is insured either by their employer or by the government or through the fees levied on the visa. In the ASEAN, Indonesia probably did one of the best things that any country could have done. They learned out of the Affordable Care Act, the Obamacare, so to say. They learned from India's failures and some of its regional successes. They took a leaf out of Singapore, they took a leaf out of Malaysia, and they produced something which is world-class. I happened to be there around the time when this implementation was done. In January 1, 2014, I was in one of the hospitals when it's called BPJS, that's the scheme. And it was so detailed, so meticulous. It took care of primary care, secondary care, and even tertiary care, with charges being defined, with days of stay being defined, with utilization being defined, with data being captured. It was one of the best models of implementation. JKN, as they call it, is the body, is the central body put in by legislation via parliament. It's called Jaminan Kesehatan National, which means the health of the population. So this body has independent authority to scrutinize institutions and hold you and debar you if they find you violating the constitutional norms of running this scheme. And this scheme moved across to all and made healthcare kind of viable there, because if you can imagine 17,000 islands, private healthcare was there in small forms. You had government institutions in small forms. All of them were covered. So government institutions saw greater utilizations, and so did my private hospital where I worked, saw greater utilization of healthcare services, but you couldn't fool the public exchequer, or you couldn't find ways to go around it. They were very, very clear on how much they would pay when they would pay, how soon they would pay, and for what you can get paid. A model like that for 400 million population is unheard of. They've done a phenomenal job. And as I know, it continues to grow in strength in leaps and bounds over the years. Healthcare exhibitions, again, these are all innovative things that keep happening in Dubai, and you see that happening even in Singapore. They are big hubs for a lot of innovations and a lot of exhibitions where intellectual, sharing happens, a lot of ideas, creative ideas get shared. So again, these two are zones where such huge learning continue to happen. Next slide. Accreditation. Pardon me?
2 minutes, 2 more minutes.
Oh, all right. I'll have to quickly hurry this up. But that said, you can see in accreditation and standardization, you see the Joint Commission and Accreditation Canada playing a large role in GCC, whereas in ASEAN, you have the American, Canadian, and the Australian. Regional bodies like NABH have sprung up all across in those countries, and you can see Abu Dhabi and Dubai and Saudi having their own accreditations. And you can also see Indonesia had a very successful model called CARS. Malaysia has, Singapore has. So they're also learning from these exercises and making it more affordable, accessible, customizable to their region, which is the key, and promote quality and patient safety. Next slide. This in just, it talks very, very generically. I wish we had more time around it, but just want to sum up with what we were doing. What I shared with you all was the GCC model and the ASEAN model. There is so much that can be said about it, but I think the presentation would give you a ballpark figure and a broad structural framework of how things happen. Just moving to my organization, something that we've done in the past 2 to 3 years, I'd like to just showcase. Zero Harm was initiated by the Joint Commission along with the American College of Healthcare Executives way back in 15 or 16 of 2000, which is basically talking about getting healthcare to reach zero, which was modeled around the Six Sigma and making sure that there is no harm caused to a patient. It was an independent work that was happening. We reached out to JCI and they were kind enough to share some of those models. So we've studied, and my quality head and the teams have implemented some parts of Zero Harm. This is not yet available for public. We were leaders in it. We just moved ahead and we got a chance to kind of learn from it. We did American College of Healthcare Executives Forum way back in 2018. We got the Dubai team here. We've done something with the customer advisory group. I guess many hospitals have already done it. Huge learning when you get patients to be members of committee of a hospital, and they can share you tons of information and they become the torch bearers for your service. All of this is familiar and nothing new. We also managed to get the Joint Commission International CEO, Paula Wilson, to visit Kuwait because we had only 2 accredited hospitals in Kuwait, and we managed to do that visit in 2018. We do quite a bit of work in and around, very similar to what is happening in the rest of the world, but some key initiatives have been shared here. If you need any further information, we'll be glad to share at a later point in time. I'll end this with my last slide, Raj. The last slide is on COVID. I don't need to say, but both regions, both ASEAN and GCC, are struggling, like every other part of the world, in controlling. One key reason to this is that a large percentage of the population are expatriate. They come in and they live in smaller residential colonies. Singapore and Malaysia have not been able to control because they've got a similar problem like the whole of GCC. So you've got a house where 8, 10, 15, 20 people are staying, and in such places, social distancing is a dream. So you're not able to control despite your best efforts. The government has done phenomenal work in GCC, I would say, and same with ASEAN and every other part of the world. But the problems continue to exist. So as long as we work towards finding these solutions as the markets are opening, it's going to be a huge challenge. There is a lot of misinformation around PCR testing, rapid testing, quick testing, social norms, distancing. So you can see a lot of misuse, misinformation, abuse that is happening across the globe. I guess as healthcare providers and healthcare institutions, we have the moral responsibility of taking care of what's happening in our organization and sharing those messages to other parts of the world. You can't change the world, but you can change the way your organization works. And I think there's nothing that one can do but change, relearn, unlearn, and keep learning as we move ahead. Thank you very much. I hope it has been useful. We'll be glad to share as much as information that is required as we move ahead. Thank you very much. Thank you, Raj.
Thanks, thank you, Alex. It was quite a good insight on both the left and right of India, the GCC and the ASEAN. And it's indeed important to note that though both are, contributed by a lot of nations, the number of JCI accredited organizations over there are much higher than a bigger country like India. I'm sure that the answer lies with the good efforts done by NABH and various other accrediting bodies here, that Indian hospitals focus on those accreditations. And it's a good start point, but yeah, still JCI is at the pinnacle, and various other accreditations are coming up. So it's going to be great. Any other panelists would like to throw some light on that?
I just would like to ask one question.
Yeah.
Dr. Nanda, please continue. I'll do it later.
No, please go ahead.
Yeah. Doctor, just would like to ask, since you're talking about implementation of health technologies and innovative technologies, how strong are the data protection laws and the data privacy laws in these two respective regions that you were talking about? Ultimately, that is what matters if you really have to implement health technologies in a large scale basis.
To
Alex?
give yes, just to give some insights around it. Most of the data, at least in the GCC, they follow what the West is doing. So most of what is available is HIPAA compliant. The Arab laws itself, so to say, or the regional laws itself are very strong about sharing information. So you can't just port information from one organization to the other. They're pretty strict because they're small and it's a manageable size. I can't say that of Southeast Asia. Singapore and Malaysia did a phenomenal job, but the rest of ASEAN just couldn't manage it, in the sense because it's such a large population. So regulation, implementation, controls were not as strong. Yeah, I think that should answer the question.
Yeah, thank you so much.
Pleasure.
Yeah, Dr. Rana, would you like to add on something?
Yeah, thanks, Alex, for a wonderful presentation, and quite interesting. And I feel always happy when someone is presenting information what he presented, about accreditation, particularly on accreditation. He talks about different JCI, Canadian, Australian. Because I used to talk, and I keep talking all these, but I feel happy personally when I get to know what people are saying about different systems and how they are experiencing. Because as Raju mentioned about the number of hospitals accredited by JCI and GCC, with a simple reason, because JCI was existing long back. Even we at NAB started in 2006, and JCI is built in 1935, 55, and then reshaped for many years. So that one reason, and other obvious reasons for internationally recognized accreditation. Basically, people say we got international accreditation. That's a wrong term actually. It is internationally recognized accreditation programs offered by a couple of, but I'm happy that in my time only in 2010, NABH started International, NABH International. We did accredit 5 in Philippines, and we have one in Nepal and a couple of other countries. So I think it's a time of globalization, as Alex mentioned very rightly. most of the countries now have their own accreditation programs in different countries. Earlier it was not there. Even 10 years ago, they were not there. So now people are moving from globalization to national things to build more strong systems. But still, the trend will continue to have internationally recognized for their own purposes, like medical travel. So I think it's a very good insight, Alex. Thank you very much once again, and look forward to hear you more about many things going around that part of the world. Thank you very much.
Thanks to the panel members for this discussion session. Over to you, Mandakini Madam.